Just a quick thank you to Chris and Chris and the Academy for inviting me. It's an honor to be here in front of such an esteemed audience. Today I'm going to be talking about upper limb trial fittings and preparatory prostheses. So to begin with, just to kind of get an idea of where I'm coming from so we can all agree on a common definition of what we're going to be discussing. The trial fitting is an interim fitting process in which the optimal choice of componentry has been integrated and only minor changes can be made before the definitive is delivered. The preparatory prosthesis itself is going to be a prosthesis providing an opportunity to train and evaluate the patient utilizing different components, materials, suspension methods, socket designs, and control strategies. And we're all familiar with the definitive, obviously. Just to go back to the preparatory, I'd like to also just say that it's one of the tools that we use to validate and to really send home what we're trying to prove when we're dealing with the third-party payers. So we'll get into that a little bit more. Some of the learning objectives and criteria I'm going to be discussing today: the medical and patient management, fitting considerations and technical considerations, outcome measures, and the demographics. So when we're talking about medical and patient management, we already kind of alluded to the need for early intervention. I think that's something that we all understand pretty well. And then obviously consistent continuity of care, followed by solid communication. When I'm dealing with a patient, I really like to build a rapport with them, and I like to keep communication as open as I possibly can so that when they come back to my office after they've been wearing a preparatory, they're more likely to sit down with me and kind of tell me what was happening, how things went with their ADL, any problems that they ran into, and I find that helps me address their issues a little bit quicker and get them back on track so they can follow through with the rest of the preparatory fitting into the trial phase. And then the clinical team, of course, we're talking about physiatrists, physicians. Obviously, an OT is very essential to the whole team. A physical therapist, if need be, a caseworker, and at the very center of all that, the patient, which is really the whole reason that we're there to begin with. And then on a side note, while they may not necessarily be an advocate to the patient, they are an essential portion of the clinical team would be the third-party payer themselves. So outcome measures. Rejection probabilities increase when function, comfort, cosmesis, patient expectations, et cetera, aren't addressed thoroughly. Speaking to that, I've had a lot of patients who walk in my door. They've been fed elsewhere. They might have some issues with comfort or cosmesis. Those are something we always want to address immediately. If you don't have a prosthesis that's going to suspend well or one that's not comfortable for them to wear, they're going to reject it immediately. And then from the patient expectation standpoint, when we have a new patient that walks in the door, they may have seen on 20/20 or 60 Minutes the new latest cutting edge, whether it's the Johns Hopkins arm or Touch Bionics iLimb or the B-Bionic hand. They come in and they kind of have a false sense of what the reality of wearing that prosthesis is going to be and what the actual technology can provide to them. So I like to kind of reel them in and realign their expectations a little bit so that they have a more realistic idea of what they're going to be receiving and how it's going to work. And then as far as the preparatory prosthesis offers a win for the patient, the provider, and the payer. I'd like to send home that when you're dealing with a patient and you send them out for a preparatory fitting, they're going to spend a lot of time working with the ADL. They're going to spend a lot of time evaluating the prosthesis when you're not involved. They're also going to spend some time with the DOT, obviously, who's going to train them how to train themselves while they're at home. That's part of the winning situation. The provider and the team, we benefit from the standpoint that it's a successful outcome, and it's something that we can take back and apply later to other patients who are going to be coming through our practice. And then from the standpoint of the payer, I think that they're more likely to be on board with paying for whatever it is that you plan on providing for that patient, as long as you can document and validate what you're doing. And I think they're more likely to be happy that they're actually paying for it, as Chris noted, that they're not going to be hanging the prosthesis up in a closet when they get home. So some technical considerations. When we're dealing with partial hands especially, it's always nice to anticipate problems. We've done a few of those fittings, and sometimes you just run into issues where you weren't really anticipating something that pops up. You have to deal with the problem and kind of move forward. On the left there, you'll see it's a Ottobock myoelectric hand, a PVC frame, and the elbow that's actually underneath that's an electronic elbow was for a patient who lost his arm in an auto accident. And he came in and he said, I want something that's going to be fully electronic, but it has to be extremely cosmetic. I wanted something that was aesthetically appealing for his peers. And we were looking at the Boston elbow and the Utah, but the problem with that was Once we had a complete skin on it and a full covered foam cover on it, the girth of those two systems were going to be a little bit too much for him to deal with. So we opted to try this VASI elbow, which was provided to us by LTI on a temporary basis. It's actually a pediatric elbow, but the nice thing about it was that we could put a full-length foam cover on it and the skin, and right there I'm basically just evaluating whether or not we're going to be able to get full flexion and whether there was enough lift capability to overcome the foam and the skin itself. And then on the right, that's the partial hand patient that I'll be getting into shortly, and it's basically just a breakdown of all the components and how things laid out. When we're dealing with partial hands, like I said, the alignment is something that's key, and it's something that's very, once you start working with it, it becomes a little bit easier, but initially it's something that you really have to spend some serious time on. Fitting considerations: motivation, determination, and demeanor. These are three things that are key in any patient that walks in our door. I want a patient that's motivated, and if I have to sit down with them and kind of talk about previous issues they've had, maybe they were fit someplace else and they were maybe mishandled, or the prosthesis didn't ever quite fit the way they expected it to, I want to talk them through it. I want to build a rapport with them. And then the determination and demeanor, I find that the more I speak with my patients and the more they feel like I'm on their side and I'm advocating for them, their determination, their motivation, their demeanor always improves. And then as far as the level of complexity and necessity of independence, that's pretty basic. If we're dealing with a transhumeral versus a transradial, those fitting considerations are going to be a little bit different. And then necessity of independence. If we're dealing with a bilateral versus a unilateral transradial, obviously you have to spend a little bit more time on the fitting and make sure that the patient's getting as much function out of it as they possibly can. And then going back to the clinical team, the more comprehensive, the more resources that are available to that patient. So if I'm dealing with somebody who has an OT, maybe they need a PT, all of those minds culminating together really put the patient in play a little bit more of a functional standpoint, so that we can all meet in the middle and try to make that experience for them the best we can. And we'll talk about gadget tolerance a little bit later, so I'll come back to that. The demographic. Last I spoke with Chris, I think we talked about the number of CPOs that are in the United States, and we came up with a number that's about 3,500. Last I actually counted in 2010 when the registry came out, it was 3,289, I think. Of those 3,500 CP and CPOs, we treat about 2,000 new upper limb patients a year. So to break that down, if we were to divide those 2,000 patients up equally amongst all 3,500 of us, they're going to see a patient, one of these new patients, every 1 3/4 years. And likewise, with about 7,000 physiatrists, they'll see a new patient every 3.5 years. And for OTs, which I'm approximating there's about 80,000, they're going to see one of these new patients every 40 years. Certainly, I'd like to just throw that out there. If there's any OTs in the audience and they have current information, I would be glad to see it. I'd really like to adapt the slide and make it a little bit more current. This information was given to me by the OT professor down at the Medical College of Ohio. So why bother with a preparatory? It assesses the motivation of the patient, the determination, and the gadget tolerance. When I'm talking about gadget tolerance, it's essentially how much technology you can throw at that patient without them starting to kind of fail. If you're dealing with somebody who is looking for a simple passive or a cosmetic prosthesis, working your way towards something that's going to be myoelectric is probably not going to be up their alley. It also gives the patient a realistic idea of life relative to wearing a prosthesis. With a new amputee, they walk in your door, they have had no education, or virtually none. Basically, they come out of the emergency room, or they're in post-op follow-up, and when you meet the patient for the first time, it's really your job to educate them and let them know what life is going to be like, but they're really not going to have a really good handle on that until they're actually wearing a prosthesis and wearing it on a daily basis. It also sorts out the limitations of the device and the patient as they begin to challenge themselves. So while they're out doing their ADLs, they're wearing a preparatory. They might have problems if they're a transhumeral getting the elbow to come to 90 degrees or up to their face so that they can feed themselves. I'll show you some slides later of a patient who had a fused elbow and she wasn't able to feed herself with her sound side. So we had to make sure that with the prosthetic side that she was able to reach her mouth. It also teaches the patient how to maintain their prosthesis and educates them about possible componentry options. I think Chris alluded to some of this. As far as them maintaining their prosthesis, I want to make sure they know how to clean it. I want to make sure they know how to keep themselves clean so that there's not going to be any kind of issue there. And also educates them as far as the componentry. If I'm fitting them initially with mechanical preparatory, I want them to understand what a 5XA hook is. I want them to understand what a number 7 hook is so they have an idea of what those components have to offer them. And as we move through the progression or the pathway of the preparatory fitting, they're going to obviously get a chance to sample a myoelectric arm possibly, and maybe an elbow depending on what level they are and if they need something like that. As far as reimbursement, I could probably spend a day talking about this, so just briefly I'm going to go over it. Third-party payers respond more positively when documentation supports the medical necessity. I think we all understand what that means. As far as dealing with OTs, they provide evidence for us at arm's length. I think a lot of the insurance companies look at us like we're the greedy prosthetists, so it's important from a standpoint of building the clinical team that you have somebody who is not part of you. They're kind of at arm's length, and when the patient who you've built the preparatory for goes to see them, they have a chance to assess and evaluate the patient away from you, even though you might be there assisting them if you need to. But it's nice to have those OTs, and they're really worth their weight in gold. So if you find one who has any experience in any kind of upper limb prosthetic training, you really want to hold on to them. And if need be, you can begin to train them yourselves if they don't have that familiarity. But going back to the slide earlier, they're going to see one of those new patients every 40 years. So if you find somebody who really has an idea of what's going on in the upper limb prosthetic community, I think that's a key player there. And as far as a preparatory prosthesis is an effective approach, we usually start with a preparatory fitting with every new amputee that we see. So if we're seeing a new amputee who just had their amputation, or we're seeing a new amputee who was sent to us by somebody else, or who found us in the Yellow Pages or some places like that, we'll usually start with a preparatory. Depending on what level they are, we'll generally start at a mechanical just to assess their function, and that way we can send them to the OT, find out how they did, and that way we start to develop these limitations that they have, and we can start to build a case and kind of develop outcomes as far as what we're going to be providing them. And then also the payer will need to have more credible evidence to refute your case-specific documentation. If you build a really great case, the insurance company is going to have a hard time coming back and saying, well, this is what we found in the peer-reviewed literature. All of us here know that that group or that scope of literature is pretty small, and especially when you're talking to a case-by-case basis, the documentation is going to speak for itself that you gathered. Component acquisition. A lot of people give me the question, how do I get components to do these preparatory fittings? I know I don't have a limb bank. I don't have access to a new iLim hand or a Boston elbow. And I'd like to try them, but I don't know where to get them. So we suggest if you have the wherewithal, you can buy them. Certainly you might be able to borrow them from the manufacturer. Sometimes you can call it Boston, and they might have a second generation elbow laying around that they'd be glad to send you, or they might have something that's the third generation that they'd like to demo with you. You can basically borrow or lease. When I believe, if I'm not mistaken, when iLim first started manufacturing their hands, there was a leasing program where you could basically lease for a very nominal fee their hand for a while you could evaluate the patient and build a case in order to have that eventually delivered to the patient. And then also utilizing your facility's limb bank. I don't imagine that everyone here has a limb bank, but for those facilities that do, it's something that you can pull from. At the Institute, we have a pediatric limb bank that is funded by a charity that we work with. So you'll see some of the charity cases or the charity patients that we work with, but the limb bank has been in effect since the early 1980s. So we have hands that are dating back to 1978. We have some elbows in there that are dating back, Vazzy elbows dating back to 1978. They've been around for a long time, but what we do is we basically, we use every component that we can, and if we need to, we cannibalize them. So we might take an old steeper hand, and we might take some parts out of there, or a central processing unit, so we can keep the limb bank going. As far as patients' previous components can be retasked, often a patient's going to walk into your office, and they might have a prosthesis that they're currently wearing. It might not be fitting very well. It might not be very comfortable. It might not be functioning properly. Depending on what level it is, if it's a transcarpal hand, you're going to have difficulty, obviously, retasking that hand for something else. But if it's a quick disconnect, whether it's a steeper or an auto Bach hand, it's as easy as building them a new preparatory. You can take the quick disconnect hand off of their current prosthesis and add that to your preparatory. Saves you cost. You might not be able to utilize the electrodes because I'd like to keep their current prosthesis intact as much as I can if they're going to utilize that. If they have a problem with the prosthesis, the preparatory that I'm going to be having them evaluate, they can always take the hand off of that, snap it back on their old prosthesis until they can get a chance to come in and talk with me. So developing the system, we're talking about socket design and suspension. Those are pretty relative. Power source, pretty familiar with body or external power, and then control strategies. When we're dealing with a new patient, and this is obviously for transradials, when we're dealing with a new patient that's coming to our practice, we usually want to evaluate all four types of socket suspension and all four types of the socket designs that go with those suspensions. So we'll generally initially start with an exterior suspension sleeve and a floating brim suspension, and then move on to a roll-on silicone liner with a pin and a Northwestern fixed brim is what we're generally fitting. Now, depending on what fixed brim design you prefer, that's entirely up to you, but the patient really has no idea of what's going to be most comfortable, and if they've come to us and they've been fit someplace else and they have a prosthesis that's not fitting properly, we like to give them the option to kind of choose. So in a lot of ways, we let the patient dictate what we're going to be fitting them with. It's not so cut and dry as this is what I think that their level is going to be best fitted to. So this is Rex. He's a partial hand patient that came and saw us about a year ago, and he was previously an aircraft mechanic. And you can see he's got a transmetacarpal amputation and his thumb is intact. He lost his hand due to some cancer that he was, when he was a little boy, he was burned in a fire from an acoustic ceiling that actually melted and dripped down on his hand. And it caused an infection for a while, but when he got older, he actually developed some cancerous tumors. And so they amputated and they kept cutting fingers away until they got to this level of amputation, and he's been holding pretty tight with this for a while. Initially he came in and he said, I don't want anything that's going to be fancy. I just want something that's going to be able to let me pick things up, do things around the house, and just to kind of get an idea of where he was at with his range of motion, his function, and his demeanor. I just kind of mocked up a soft P-Lite socket that was thermoformed over his mold. You can see it's got a Plastizote opposition post. And he wore this for a couple weeks, and he came back and he said, it's really lightweight. I like that it's lightweight, and it's a little flexible. He said it's really hot though. So even with the sock on, he said it's not really getting enough air. I'd like to go to the next stage of something. Let's see what we can do with some rubber, some plastics. Interesting thing about him, since he was an aircraft mechanic, he had a really solid idea of mechanics and electronics and things like that. So when he came in, he basically sat me down and he was ready to tell me how to do my job. And that was okay. I sat down and I said, look, I'm going to do whatever I can in order to help you. You need to understand what I'm capable of doing, and now that I understand that you have a pretty good idea of understanding what I'm capable of doing, I think we can work together a little bit better. And since then, we've built a fantastic rapport. So the second generation, we started with, this is just an Orphatrans. I believe it's an ultra-soft Orphatrans socket, and you can see there was just some strapping on there so we could adjust the tightness of the socket. Initially, a stainless steel opposition post with a little bit of a radius to it, and I put some surgical tubing over it just to give him some gription. And you can see he does pretty well as far as holding round objects. So he was able to open jars and bottles and things like that at home, which he thought was pretty cool. He's still wearing the sock, and we ended up getting away from that with some of the next generations. Now here you see on the left slide, that's just the socket iterations that we went through. And in my first or second slide, I talked a little bit about evaluating different materials. That top left socket's a Uvex. Next to that one is an Orphatrans socket, which was the Caucasian colored, and it was a firmer durometer than the first socket, which you see on the right there. And then the bottom left is, I believe that was a Serlin, and we also tried a middle durometer of the Orphatrans. And since then, we've tried a couple other materials too, but I just wanted to give you an idea of the different types of materials or the different reasons that we would try those different types of materials. I had fit him one time with an Orphatrans socket similar to number 3 up there in the top right corner. And over the top, I made a laminated frame with kind of a fitting that I made so that he could switch out kind of like a quick disconnect opposition post fitting. Just something that I kind of rigged up so he could evaluate it to see if it was going to be something functional for him. What he noticed was when he was outside in the fall and it was a little bit cooler out, he was raking leaves. that lamination and the thicker Orphitrans sucked all the heat out of his hand. So he'd have to go inside and warm up a little bit before he could go back in there, which I thought was really interesting because we fit him with similar designs and it didn't have the same effect. But it acted as a heat sink, so we kept searching for different materials that we would be able to use on him. The right slide you see there, that's the Orphitrans socket. He came and he said, you know, I was at Sears this week earlier and I picked up this treadmill so I could walk inside while it's colder in the colder winter months. And I really wanted to assemble this and I had some issues. He's like, can you build me a thumb vise? Is pretty much what he called it. And I'm looking at him and I'm not exactly sure what you mean, Rex. And he's like, I want something that is going to be part of the opposition post that's going to be able to clamp down on something and maybe have a thumb screw on the back of it so I can tighten it at will, so I can clamp down on a nut or a bolt and it helps me assemble things. And I said, okay, we'll give this a try. You know, I'm pretty sure that we had some materials that I'd be able to at least evaluate to see if we could try this. So this was the first iteration, and the first and second iterations were pretty much terrible. They didn't work at all. And he said, you know, this is going to be a little harder than we expect. Another thing that he noted too, he said the first 90% of making these improvements, that comes really easy. When you get down to that last 10% of that function that you're trying to eke out of a system, he's like, that's where the work really comes in. And that's about where we were at this point. We were really trying to get him something that was going to be functional. And ultimately, I told him that he should probably speak with a CNC machinist, or if he'd like to, we had one next door that I could contact and see if we could build him something that would be similar to this. After we thought about it for a while, though, we ended up going to the next design. And the design after this, and I'll show you that. But in this design, he was kind of evaluating how to hold a fork and whether he could cut meat and things like that. And you can see on the left there, he basically just jammed a fork underneath the rim of, or the edge of the socket, and that worked pretty well for him. In the next generation, we added a little bit of strapping, so we had a channel to run the neck of the fork through. And then he was still kind of pushing, when he was pushing down on a piece of meat, it was still, the fork was moving proximally. So we ended up putting just a little bit of a basket on the back of that to really give him some force. And when he was cutting meat or he was using a knife, or even if he was trying to use a screwdriver or something, he really had quite a bit of torque that he could use. So this was the final fitting of the pre-definitive. You can see that's an Orphitrans socket. We just kind of did a little bit of a build-up on the distal end there so that the opposition post would have something to attach to and gave it a little bit more girth. We ended up holding the straps that we had before, except for the basket that was proximal. But the distal strapping there, or the distal channel, we kept, which he finds pretty useful. Now, we were talking earlier about that thumb vise. Instead of using a thumb vise, he went to the hardware store. And if you look in the background, I'm sorry, I don't have a laser pointer, but if you look in the background, you'll see that there's all those tools, different types of needle nose pliers and scissors and all types of assortments of vice grips and things. And he could jam those basically into that little strap, and he could hold whatever he needed. So for the time being, that worked pretty well. And also, you see the opposition post, it still has the radius in it, and that's just covered with a little bit of P-light. So he has that gription. The surgical tubing that we previously used, it wasn't really cutting it. So we went to this because it was a little bit softer and a little bit more pliable. And you can't really see, but on that right slide, there's a little bit of a radius that's turned out. So when he was holding his cane, or he was holding the steering wheel while he was driving, it didn't shift the socket and make it uncomfortable. And then on the very tip of the opposition post, you can see there's a little slit cut out. And he did that for two reasons. He wanted it because he could hold a nail, and if he wanted to nail something together, because he's usually working in the yard or in his house. He's an older gentleman that just lives alone and kind of tinkers. And he also wanted to be able to hold the fork, so instead of having the basket on the proximal aspect of the strap that you saw earlier, he could lay the side of the fork in there and run the back of the fork through that channel, the fabric channel on the right there, and it was a pretty secure, stable fit for him. And this is the progression that we went into with the digital, the Pro digits, and you can see on the right that's the completed prosthesis, or at least the completed preparatory that we evaluated, and on the left you kind of get a sense of the componentry that goes into those fittings. So you have a battery, the electrodes, the on-off charging port, the central processing unit, and obviously the wiring and the fingers themselves. And at first he was saying, you know what, this is not something I'm going to want. I was an aircraft mechanic. I know that these things break. I see a lot of plastic. I see some wires. I see some string. He's like, I'm going to break this in a week. I'm going to be back here every week. And I said, well, tell you what, we're going to build you a preparatory just for grins to see how you do with it. You're a fantastic, because if you remember the first slide I showed you of him, he was a fantastic anatomical candidate. So we thought we're going to get our feet wet and just kind of get a sense of whether or not this is going to be something that would be functional for somebody that's at your level, even though you might not be receiving this prosthesis. So here's the video that you're seeing on the right. Right there, he's picking up a Q-tip, and he kind of goes through a series of different things that he's manipulating, and I like that. I'm sorry for the graininess of the video itself. And on the left there, you see that the initial high-temperature vulcanized socket that we fit him with, we're using intrinsic muscles right there, so the thenar and the hypothenar and the lateral muscles. We were shifting the electrodes around, trying to find the best location for those electrodes. And we were using an Ottobock hand, just using remote electrodes and preamplifiers in order to evaluate whether or not he even had function before we went to the stage on the right. And then if you look closely at the video on the right, you can see that the electrodes are actually more proximal. They're laying on the extensors and the flexors of the forearm, and it seemed like we just had a little bit better control with those. The video itself, what I liked about it was he starts with the Q-tip right here, and then he moves along to the baby powder, which is a little bit bigger. The fact that he could pick the Q-tip up right off the table I thought was fantastic, and he was pretty impressed with this. Now mind you, this was after quite a bit of alignment. We worked pretty hard to make sure that we were tweaking the alignment to his liking, and that it seemed every time we tweak it a little bit, he was able to do more and more and more. And since we never got to a definitive phase or even a preparatory phase that he was able to take home, unfortunately we didn't get a chance to evaluate that more thoroughly. But the most important thing that I thought about this video was right here, where he's opening the bottle of soap, and he turned to me and he said, "This is fantastic." He's like, if I was working again, or if I was in an industrial situation where I had a job, he's like, I would be able to put things together. I would be able to assemble things. He's like, I never thought I'd be able to do that again using actual fingers and using two hands. And I thought that was really impressive that he said. The one last thing I'll mention about him is he was right-hand dominant. He mentioned to me that if he was left-hand dominant, which he was the side that he's obviously missing, that these fingers would have been something that he would definitely have wanted, and they would have been essential to him being able to function on a day-to-day basis. But given that his right hand, which he was the dominant side, was doing 90% of the work every day anyway, he said, that's not something I really need. So we get into a transradial fitting. She's obviously a very short transradial fitting. This was secondary to frostbite, and I'll show you her contralateral limb in a minute, but you can see there's a little bit of redundant tissue on the left slide there, but those lumps that you're seeing on the distal end, those are actually bony prominences. And then on the right, obviously, that's in her full flexion. So she was going to be a difficult fit from the get-go if we wanted to really eke out some functionality, if we were going to fit her with anything that was going to be heavier than a passive. And that's her contralateral limb, and you can see there's quite a bit of grafting that went on there. Her left hand was semi-functional, but still, we wanted to give her something with the right prosthesis that she was really going to be able to benefit from. So we started with the components trial, and you see on the left there, we fit her with a steeper myoelectric hand. This was actually a pediatric hand. And the reason that we did that was because we wanted to keep the weight down as much as we could. And I'll show you why in a minute. And then on the right there, you got the motion control ETD that she evaluated, and also the Ottobock Greifer that she evaluated. And she liked both of the ETD and the Greifer, but it was something that was not necessarily cosmetically appealing to her. So she ended up sticking with the steeper hand. I'm sorry, that is a VASI hand. And you'll notice that the prosthesis itself is pretty short. In relation to the Greifer, it's almost as long as the Greifer, and the reason that we did that was because of those bony prominences. She found that when we made the prosthesis as long as it was supposed to be anatomically, that it was cantilevering over those rough spots and those bony prominences, and it was pretty painful for her. So we ended up shortening it, which she was fine with because it gave her a little bit more leverage. And we used the pediatric hand to cut down on the weight, and she did fantastic with this. And we ended up using internal batteries on here, so you see the charge port and the on-off switch there on the medial side. And she also wanted something that was passive and lightweight. So we fit her with a silicone pin locking suspension just to see how she was going to do with that. And then on the right there, it's a laminated socket with a Scotch cast forearm shell that's just been painted with some mannequin skin. And if you look back at this really quick, that's the same too. That's also a laminated socket with the Scotch cast forearm, so it's a preparatory phase. And she also liked gardening. She liked being outside, and she had a guardian because her cognitive abilities were a little shaky. So she was staying with somebody who was taking care of her, and her guardian liked to take her out into the yard, and they would do some flower potting and things like that. They might do some gardening. They would rake up the yard, things like that. And she wanted to be able to pot flowers herself. So rather than call TAD or TRS, I said, I'm going to take a trip to the hardware store and see if there's something that I can find there. So I found just a couple pieces for garden tooling and took them back to the lab and kind of hacked them apart and found a way to stick them together so that we could use the USMC quick disconnect wrist that we were using with the stud on the back of the Ottobock spring-loaded passive hand, so she could just switch between those if she wanted to. So when she was riding her bike with her guardian, she could be using the passive, and it was spring-loaded, so it was easy enough for her to get on and off the handlebars. And if she wanted something to wear when she was going out for dinner, this was obviously what she would be wearing. But if she was tinkering around at home or evaluating what she could be doing, we would put these tools on her and give her a chance to kind of play around with those. Eventually, we would have built her some other tools, but we decided we would stick with these for the time being. So moving along, this is a brachial plexus injury secondary to a motorcycle injury, and you can see there's some grafting and some muscle transplant that went on. And if you see that right slide there, in the brachial fold, there's quite a bit of muscle bunching. That was as much as he could lift his arm. He was basically at 90 degrees, maybe a little bit less. And his lift ability was probably half of what it should have been naturally. So if he really wanted to lift something that was heavy, he needed some kind of assist. These were taken from the article that we wrote, so sorry about the black and white, but you'll see there on the top left, we initially fit him with a mechanical preparatory and standard locking joints. And I'll talk more about the joints because I thought that was an interesting and a key point. But you'll also see there's a linear transducer on the distal end of that socket. And the reason for that was we could switch back and forth between components. So we built in one preparatory, but it had both capabilities to work mechanically and electronically. So we evaluated the number 7 hook for a while, and then we could just unhook the cable and hook it into the linear transducer and snap on a quick disconnect greifer or a hand for that. And he'd be able to evaluate that. So we sent him to an OT, and they would do an assessment and kind of give us some feedback of what he needed and what he wanted. So you'll see there on the bottom right, he was evaluating the Ottobock Mayo hand. And as I mentioned, you see that the joints that we're using were locking joints. So the lock itself is on the medial side, and the locking cable is pointed proximally. When we get to a later slide, that'll mean a little bit more. But in this case, we were fitting the preparatory with the greifer. You can see the linear transducer is obscured because we covered it with a polyethylene shell just to make sure everything was streamlined and smooth. And he evaluated this for a while. The elbow was activated with a harness cable so that he could get a little bit more lift assist out of that. And the harness wasn't something he really enjoyed, but bottom line was that he still needed something to help him lift that arm up if he wanted to get it past 90, especially if there was a load on it. So when we went to the finalized design, we came up with a rigid humeral cuff, this laminated design, and you'll notice that the joints have switched sides now. So on his lateral side is where the lock went, and now it's pointed distally. So what he could do was, he could reach over with his sound side, he could prop his arm up and give it the proper lift assist that he needed, and at the same simultaneous time, he could pull the lock and lock it into any position that he needed. And he did pretty fantastic with this. If we have some time at the end of this, if I don't run over, then I've got some interesting slides of him trying some activity-specific prostheses. He was a boater and a fisherman, so he was a pretty interesting guy to work with. This is one of the most interesting cases I've ever had the pleasure of working on. This is Irina. She was about 13 at the time that we fit this prosthesis, and now she's about 15. You'll notice that her stature is pretty small. That's because she was born without both her femurs. In this case, you'll notice that she's also a very short transhumeral, and her right arm is fused at around 135, 140 degrees. So she couldn't really get to her face if she needed to feed herself with the sound side. So this was her previous prosthesis, and you can see there's a little bit of a cant to the forearm so that she was able to reach her mouth a little bit easier. And there's her range of motion capabilities. what she ran into was the issue of when she would pick something up, she would drop it because the rubber bands, there wasn't enough of them to really grab hold of something, and she didn't have enough ability to use the harness properly or the prosthesis to hold on to what she really needed it to. So that was a functional limitation that we had to address. So we began with just a weighted test socket, and we always weight our test sockets. Even if I'm delivering like 4 different types of socket designs and suspension designs for a patient, I always want to put a weight that's going to simulate the prosthesis, and that's something we always do. So let's say her prosthesis probably weighed, let's say, around 2.5 pounds. So you have her shoulder saddle and a chest strap, which seemed to be a little bit more comfortable for her, rather than the figure-of-8 harness, which was really digging into her axilla. So we fit her with the shoulder saddle, so she'd carry a little bit more weight on top of her shoulder, and the chest strap was obviously a little bit more comfortable for her under the axilla. And then the UVEX test socket with the frame on it. Now the frame itself, that's filled with about 2.5 pounds of lead shot. So we could really simulate the weight of the prosthesis, and she could wear that for several days. We would send her home for this, with this, and we would tell her to wear this for about 6 hours a day for probably 3 consecutive days to get a really good idea of whether or not the suspension was going to be keyed in and if the comfort was going to be there, because if it wasn't going to be comfortable for her, she obviously wasn't going to wear it. And on the left there, or on the right there, you just kind of see what the posterior aspect of that chest strap looks like. And eventually, we ended up putting an electrode array, which you'll see later, into the shoulder saddle, using that as the open signal on the upper trapezius. And then we used, I believe, an anterior sight for the bicep for her close. So here's her hybrid temporary design, and you can see that we started with just a Hosmer elbow. The frame itself is made up of PVC. That's something that we really utilize. It's cheap, it's quick, it's easy to mold. It's a very functional component as far as a preparatory design goes. You can kind of throw pieces together, Frankenstein them, if you will, and you can send somebody out the door with something that's going to be pretty stable and pretty functional. It's going to be robust enough for them to handle a little bit of treatment on an ADL task. So we tried this for a while, and we noticed, even though it was the hybrid design since she previously had the mechanical, she wasn't able to get the elbow up past 90 because the hand was a little bit heavier than she anticipated. So this is just a shot of the shoulder saddle and chest strap and the electrode configuration. So you see the 2 gray electrodes there on the right. Those are the live electrodes, and then the green one is the ground, and those were running down to remote amplifiers. And then on the shoulder saddle and chest strap array, you can kind of see how the actual cabling was configured. So the limitations that we ran into, as I mentioned, she couldn't really lift it past 90 degrees, which is a pretty huge limitation considering she needed to feed herself with the left hand. So initially we were thinking we could put some different kind of excursion amplifier in there, or we might be able to address that in another way. It turned out that even though we tried some of those things, they didn't really seem to augment the ability for her to function properly. So we moved to an electronic elbow. And this is, as I was mentioning, a Vasi elbow from 1978. The proximal battery that you see in the left slide, that runs the elbow, and the distal battery runs the hand itself. And eventually we combined those two into a nice set of internal batteries that ran the whole system. But initially this is where we were at, and this was from our limb bank. So we utilized the hand from our limb bank and the elbow from our limb bank. And you can see that she has no problem getting up to her or closer to her face now with the electronic elbow. The nice option was that when we went to the newer elbow, the new Vasi elbow is even a little bit faster, and it also gets a little bit more flexion too, so she got a little bit closer even yet. And this is a picture of the laminated prosthesis that we used for the trial fitting. You'll see that the proximal portion is all laminated, the socket and the actual humeral shell, and it's been attached directly to the elbow itself, but the distal forearm is still in a preparatory phase where we're using the PVC, and we're still using the 2 different batteries. The one that was down in the forearm for the hand itself, and then the internal batteries that were up into the forearm shell for the elbow, until we had a chance to switch over the whole system. And that just kind of gives you 2 different views, so you can appreciate the different types of materials that we're using and what the socket configuration was looking like. So her current definitive, you'll notice she's got a switch on the anterior portion and she's got a switch on the posterior portion as well. She wore this before we actually got to this phase. In the phase that we're in right now, there's a wrist rotator in there, which you'll see in the next slide, but she wore this without the wrist rotator for a couple months, and she said, you know, I like the elbow, it's faster, it's quieter, because the 1978 elbow was obviously pretty old, so it was a little bit creaky, a little bit grindy from the gears and things like that. She liked the fact that it was faster and that she could reach her mouth a little bit easier, but the problem was when she picked something up, she still couldn't reach her mouth because the hand was going to be she would have to reach over and reposition the hand, and she wanted to be able to do that without having to reposition. So we decided that we'd try this wrist rotator. We called LTI and we said, do you have anything that would be applicable for a pediatric patient? And they said, well, we've been working on one. We have 2 prototypes, and that's, you know, we'll send you one of them. So there's 2 prototypes for this LTI wrist rotator in the world, and our patient happens to have one of them. And it's a pretty interesting design. I'll show it to you in just a minute. But initially, we tried to have the elbow functioning with the posterior switch, which she did really well with. And it's just an Ottobock micro switch. And then anteriorly, you'll see that the other switch that ran the rotator. So in her case, she had simultaneous triple control, and we'll talk a little bit more about that in a minute. This is just a close-up of the posterior view and how that was harnessed, and the anterior chest strap and the rotator activation. You can see also on the middle of the chest strap there's like a little finger loop so that she could get her finger in there and just kind of pop the prosthesis off if she needed to get out of it quickly. And ultimately, if she was going to don the prosthesis, she needed a little bit of help in the morning, but from the standpoint of being able to get out of the prosthesis herself, she was pleased that we built that in there for her, and it was just a little additional feature that she really enjoyed. And then on the right there, you'll see that she's using the wrist rotator. And when she was using the wrist rotator, she would pick whatever she needed up. She would use the posterior control to bring the elbow up, and at the same time, she would be abducting directly outwards. So she would be engaging the wrist rotator. So she would pick something up, and then she could bring up the piece of food while she was rotating it towards her mouth, and she could feed herself pretty well with that. There's a picture of the rotator, and that's her getting up there to feed herself. The rotator itself had a friction setting, and it also had like a flexi wrist feature on it too, so she could position that hand in pretty much infinite positions. And we'll briefly talk about sequential versus simultaneous. I was reading an article by Richard Weir recently that was taken out of the Grasping the Future Advances in Power Upper Limb Prosthetics that was recently released online. And he talks about sequential control being slow and unintuitive. And I think that we can all appreciate that. If we had to pick something up and then bring it up to our face instead of pick something up while we're moving down to reach it, it would be obviously unintuitive and it would slow us down quite a bit. So the ability to simultaneously control 2 or 3 degrees of freedom in a standard myoelectric arm prosthesis would represent a significant advance. And in her case, that's what we were so happy that we were able to provide, because she was able to have triple control and it was simultaneous. And we're briefly going to talk about shoulder disarticulations. You'll see on the x-ray on the left that the patient has a very short transhumeral, and based on what you see on the right, if we had had the chance to consult with the surgeon beforehand, I think that we would definitely recommended that the humerus be taken out. You'll see later in the final fitting that the aesthetic finish to it was just not as great as it could have been. But she was still a really interesting case. She lost her arm because of Berger's disease. And you'll see there on the preparatory progression, we fit her with a monolithic hybrid. So it was basically just a shoulder cap almost that was laminated with the electrodes in it for on the right side there. And on the left side, we fit her with the mechanical elbow of Myo hand, and she didn't have a shoulder joint in that. It was basically just all set so that we could find out whether or not that was going to be an issue for her or not, because she wanted something that was lighter. She really didn't want us to hang all of that technology on her. But on the right, we ended up going with, first we went with a locking shoulder joint, and it turned out that she really didn't need it. She had trouble activating it, so we took that out and went with a friction joint, and that seemed to do just fine. Once again, you'll see that she's a chest strap that we really like to use. Even though it doesn't give them that crisp function, especially when you're dealing with a transhumeral, having that shoulder or that chest strap gives them a little bit more comfort throughout their day-to-day. And here you see the final fitting, and the outset from the prosthetic arm is about 3 inches more lateral than it really needs to be. So it would have been nice to be able to bring that in a little bit more, but you can do, you have to do it with what you have. So, and then you see on the right slide there, we fit her with a linear transducer. She had pretty great control of the elbow with that. And I really like the linear transducers rather than the switch. In a lot of cases, we end up going to a linear transducer once the patient has a chance to evaluate the switch, just because it gives them a little bit more finite control. And when you're dealing with the switch, you have probably, I'd say, 3/8 to 1/2 of an inch of travel to really get that to activate, depending on whether or not you have the settings for the open or the lift or the close or the drop of the elbow set. With the linear transducer, it's all relative to how much you pull it out. And it's kind of a nice feature. And here you see the inside of the socket, just the electrode array. So we're using the upper trapezius and the lateral pectoralis. And then you see her there in OT, and she's knitting, which is she loved crocheting, she loved knitting, 2 of her hobbies that she wanted to be able to return to. And here she put together a doll that was made out of just scraps of material for our office manager, and she knit a scarf for my father and myself, which I thought was pretty cool, and she did that with her Greifer. So things to take away with you today: realigning the patient's initial expectations. We talked a little bit about that. If I have somebody that's coming in and they're not really familiar with prosthetics, they're a new amputee, they weren't really educated in any kind of capacity as far as what they're going to be receiving or how the progression of rehabilitation is going to go, I really like to give them a chance to sit down with me, find out what they think they know, find out what they do know, and then talk to them so that they have a really, really solid sense of what reality is going to be like, at least until they actually wear the prosthesis, which is really going to set that in stone as far as the reality. Keeping communication open with the entire team, mostly importantly the patient. The patient's the reason we're all there, obviously, so keeping communication open between the OT and the patient, and the physician and the patient if need be. The caseworker, I think it's integral into fitting them and having it come out as functional and beneficial for that patient as possible. And then solid documentation makes the payment feasible. I think we can all understand what that's speaking to. And then trial and success as part of the process. You're going to make some errors when you're doing these preparatory fittings. It's not going to work out, but the nice thing is, since it's preparatory, it's not really an error. You're just kind of learning. You're putting things together. The patient has a chance to assess them and find out whether or not it's going to be beneficial to them. If they come back and they say, this didn't really work for me, you learned something new. And that kind of goes into your bag of tricks. And then as far as methodical progressions create the pathway, like I mentioned, when we're talking about a transhumeral, we start with the mechanical, if they haven't worn a mechanical before. If they happen to show up and they've been wearing a mechanical, then at least we have something to evaluate. So we want to make sure it's fitting properly so that when we send them to the OT, they can assess that. But we generally start with the mechanical, as I mentioned, and then move to a hybrid if need be, and then to a fully electronic prosthesis if that's something that we also have to check into. Now, just really quickly, as far as activity-specific trial fittings, this is Tommy. We've been seeing him through the charity that we work with since he was a baby. He received his first myoelectric arm when he was about 1.5 years old, and he's been wearing one ever since. He has played the cello since I think around the age of 10, and he always wore his myoelectric prosthesis to play the cello because he could hold the bow, and it really wasn't too cumbersome. But about 3 years ago, he came in for a glove replacement, and he said, "You know what? I think I'm going to get into the guitar. I'd really like to learn to play the guitar since I've been playing the cello in my high school orchestra for quite some time." So we said, okay, and he said, "I've tried holding a pick with my myoelectric, and it's just not possible." He said, "It's too cumbersome. I can't strum as accurately as I'd like to. Do you think you could build me something that might be a little bit more workable for what I'm trying to do?" And I said, "Sure, we'll see what we can come up with." So the left slide there is the initial preparatory that I came up with, and you can see it was basically a test socket that we had thrown together. It was just pulled a duplicate, as it were, over his mold. So we had done the initial myoelectric fitting, and then this was something that we had, because we keep all of our test sockets, so if a patient comes back and we're worried about the fit or they're having a problem with the fit, we can go back to our box of test sockets and just double check and make sure there's no blanching over the skin or anything that might be causing a problem. So we pulled a duplicate socket, added this PVC frame and an Autobach flexi wrist, and I just kind of mocked up a guitar pick, silver soldering a couple pieces of steel together, and threw it on a half 20 thread and let him take it home for a while. And you see the blue Spenco there. It was just so that we didn't scratch up his guitar since there was a lot of hardware. And then he wore that for about a year, and he came back and he said, "This works really great." He says, "Can we move to a definitive phase?" And I said, "Sure." So we threw it in the jig, and we got the alignment correctly, and I ended up getting rid of the Autobach Flexi wrist because we had the alignment, and we built him something that was going to be ultra lightweight. He wanted something that was short, so we had a little bit of leverage so he could strum the way he wanted to. So we made it as short as we could, and the carbon fiber socket just lightened it up that much more. And he's currently working towards getting accepted down into a music program in Florida, even though he's living in Toledo right now. And then just as a final activity-specific design, this was a prosthesis. The top left is a prosthesis that I mocked up for one of our Myo patients, and that's actually one of her previous Myo sockets that she came in for a Myo refit, and she wanted to be able to start rock climbing. So we kind of mocked this up, and like I said before, I just sort of silver soldered some steel together and bent it, and I had gone to a couple like REI stores and looked at some of the different climbing hooks or the climbing axes that they had just to see what I could build her. So we threw this together, and unfortunately, she never actually come to pick it up, but I thought I'd throw it up there for you guys just to take a look. You can see it's all Scotch casted together, so it gives a little bit more robustness. And then lastly, just to jump on board with what Chris was saying about his fishing patient, this was something that I threw together. The inside of that socket is made of a P-Lite insert. The outside is carbon fiber. It's obviously held on with that suction sleeve. And in the very end where you see that he's using to reel the rod is actually a crutch tip that we turned upside down. So he did pretty well with this. And I also built him something that was for boating so that he could drive the boat and used his the ignition, not the ignition, but the throttle. So he was fun to play around with, and it was just something that we really enjoyed working with. So I think that's it. And I just wanted to reiterate that if you guys have any questions, jot them down because I know we're going to be answering them on the panel discussion. And thank you very much.